I'm ready when you are. أنا بسامعك يا دكتور.
اوكي
أيوة كده سمعتك.
اوكي I'm sorry. هو احنا كان احمد عامل لي انميوت. نبدا ثاني. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد أشرف خلق الله أجمعين. يسعدني وشرفني اليوم أن يكون ضيفنا الكريم أستاذ الدكتور ياسر طلبة، أستاذ التخدير والرعاية المركزة والكونسلتنت in UK and Saudi Arabia. He is one of the eminent international speaker and presenter and one of SCCM instructor, a great instructor really, and also he is my great brother and great friend. He afford us his time today unconditionally, and I know that he is very, very busy, but he didn't want to waste our time, and he is insist to stream this valuable lecture for us. So thanks a million for you, Dr. Yasser. He will stream the lecture under the topic of ventilation in the 21st century. This lecture will be a reference for ventilation, starting as the journey from the basic science of ventilation to the advanced one. So everyone today will carry a voluminous and massive information about this hot topic in our daily practice. Thank you for your attendance and my greeting and appreciation for you, Dr. Yasser. The floor for you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Professor Safa. It was a great pleasure, and thank you for allowing me to share this information with all my colleagues in Egypt and whoever come from outside Egypt. I belong to Cairo University before I moved like 20, maybe 25 years back when I traveled first to England. But I still, I was Cairo University staff, and I'm still on. I'm honored to be on the Cairo University staff yet. So thank you very much, Professor Safa. And we're starting with the ventilation 21st century. Professor Safa told me to try to make the subject suitable for all levels, starting from basic to advanced. So inshallah, we'll try our best. You can stop me at any time or try to ask any questions. I don't mind. The whole idea here is to show knowledge and try to understand, inshallah. We are all, at the end of the day, we are all colleagues, and we do this for the sake of help of our patients, and we have to make the intention for the sake of Allah subhanahu wa ta'ala. So why we need ventilation? Patients are intubated, ventilated mainly because to manage acute respiratory failure. So the ventilation is, the mechanical ventilation is just a way to provide the function of the respiratory system when the respiratory system has failed. There's also other indications for mechanical ventilation rather than respiratory failure, which can be patient have apnea with the respiratory arrest, patient have clinical deterioration or shock, hypotension shock. So you intubate these patients not because of respiratory failure, because you want to, for example, reduce. In shock, you need to reduce metabolic rate, you need to insert lines, you need to manage the patients, you need to get the patient to ICU. And the best way to do this and give patient sedation, the best way to do this is to intubate and ventilate the patient. A patient have neuromuscular disease like myasthenia gravis or respiratory muscle fatigue. Patient have coma. To protect the airway, you have to intubate and ventilate. The first example about just I'll try to get the marker so you can see me better. Okay, now you can see the marker. Yeah, okay. Apnea, for example, if you have like morphine overdose or patient have any toxin which can reduce the respiratory center, and patient will need intubation ventilation. So all of these are other indications for mechanical ventilation, but the main one we're talking about is acute respiratory failure. Acute respiratory failure, as we all know, can be type 1, can be divided to type 1 and type 2. Type 1 when you have hypoxemia without CO2 retention, type 2 when you have CO2 retention. The famous example of type 1 when you have pneumonia, either viral or bacterial pneumonia or lung contusion. So all of this can cause hypoxemia without CO2 retention. Actually, the tachypnea might even lower the CO2, but the type 2 is like COPD, and this patient will have also, in addition to the hypoxemia, will have CO2 retention, hypercapnia. Mechanical ventilation, as we all know, we do it positive pressure, but in the initial phases of mechanical ventilation and the history of mechanical ventilation, they started to do this negative pressure ventilation. So and they use this iron lung. So this is like this machine looks like from the 50s and 1950s. So maybe how much now? 70 years back or something. And this called the iron lung. We don't do negative because there was high mortality with this, so they stopped doing it. They didn't use it for long, and they use this modified negative pressure ventilator called Hayek ventilator. He's an Iraqi doctor who invented this Hayek ventilator, which use a QS like درع بالعربي, درع يعني around the chest, and this will cause negative pressure. Tried to imitate the normal physiology, but unfortunately didn't work as well. But we use it as a method for physical therapy, respiratory physiotherapy mainly, but not as a method of invasive mechanical ventilation. So this is just a patient awake. We do physical therapy, and this patient had weak muscles, and we apply Hayek negative pressure ventilator in order to help the patient to reduce cough, and so this is one of the indications. So positive pressure ventilation, this is what we use for the last maybe 56 years, and has been advanced, of course. So we're talking about the recent advances in the 21st century. But this has been the cornerstone measurement of acute respiratory failure and ARDS. ARDS stands for acute respiratory distress syndrome, which is one of the main causes of acute respiratory failure. So what is ARDS? ARDS, we have the Berlin definition, which has been there for many years now, since 1992, and it has been it has to be acute, an acute disease, bilateral, and the main characteristic is hypoxemia, and you have to exclude congestive heart failure. ARDS is a syndrome. It's not like one disease. It has many etiologies. The severity can range from mild to severe. The pathology also is different, and there's biomarkers profile. This is the new definition. This is the most recent. definition has been published in May this year. And it's similar definition. The only thing they added the high flow nasal oxygen here because, and also they divide into mild and moderate and severe according to the PF ratio. We used to do this anyway before. So mild is when you have less than 300, the PF ratio is 300, so between 300 and 200. Between 200 and 100, this will be moderate, and severe will be less than 100. Of course, you need to have a PEEP on board. Also, they put here the ultrasound. This is also a new modification because now the ultrasound, lung ultrasound, and well established as a method of diagnosis rather than in addition to the X-ray and CT. And also, you need to also to exclude cardiac cause of the pulmonary edema. So it is non-cardiogenic pulmonary edema. And the acute phase can we accept up to 7 days. So as I told you, it is an heterogeneous disease, can be due to primary, so disease can start in the lung, like infection pneumonia, can be aspiration, can be lung contusion or inhalation injury, like smoke inhalation and burns. And it can be either secondary, so it's part of the multi-organ failure, like in sepsis, pancreatitis, or TIRALI, which is transfusion-related acute lung injury. Hello, I'm giving a lecture. Are you okay? Okay, thank you. Thank you. Sorry, I'm in the hospital. So this slide just to show you that when you intubate these people ARDS, the likelihood of extubation or discontinuing mechanical ventilation is less when you have severe. So if you have a severe disease, you are less likely to wean these patients because severe disease, unfortunately, it's very, you will be ventilator dependent maybe, and can lead to mortality as well. If you have mild disease, the incidence of weaning of mechanical ventilation will be higher, and moderate will be in between. Also, the pathology is different. So this is the black box is the pneumonia. This is diffuse alveolar damage. When you have diffuse alveolar damage, so the alveolar damage is higher when you go severe disease. So the more severe disease, you will have more alveolar damage, which is a bad news for the lung, and you end up with lung fibrosis and delayed recovery of the lungs. So in the mild disease, you have the infection part is higher, but it decreases when you have severe RDS, which is bad news for the lung. Also, the trajectory, you can see the trajectory mean the phases. So the early and then after that until we come late in the ARDS. So start with the healthy lung, get the causative organism, for example, like infection. Then after that, we have the oxidative phase, which we have the pulmonary edema. But this pulmonary edema, as I told you, is an inflammatory pulmonary edema. It's not cardiogenic pulmonary edema. This is the oxidative phase. If unfortunately the treatment didn't work, you go into proliferative phase and you have invasion of the macrophages and neutrophils, and this can cause fibrosis at the end. And this is, the worst case scenario when you have fibrosis of the lung and end up with chronic fibrotic changes in the lung. Like we know that, we know this from, for example, one of the causes we just seen recently, despite it's a different, of course, pathology, totally pathology different, but in COVID, people who recover from COVID, if they have severe COVID, they will end up with fibrotic lung, and they will their lifespan will be shorter and will die later from fibrosis of the lung. But if you have if you try to treat the patient early, and this proliferative and fibrotic exchange phase can be diminished, then you have a better mortality. This is also the distribution of the disease is different. So mainly is a patchy disease all over the lungs. This followed by lobar distribution of the ARDS, then followed by diffuse. So the main pathology is usually patchy. So batches of inflammation on both lungs, followed by lobar. So it can be the basal lobes here, or can be diffuse all over the lung, and this is the worst when you have the diffuse. The cornerstone of ARDS ventilator management is supportive by ventilation, by mechanical ventilation. And the main thing when you do mechanical ventilation of ARDS patients is try to limit the side effect of mechanical ventilation, because already the patient is having this pathological process going. You don't want to add to this ventilator-associated lung injury, because the ventilation itself can cause a lung injury. So you don't want to double hit. The patient has enough hit from the disease itself. So you don't want to. You want to protect the lung from the bad or side effects of mechanical ventilation. So you want to support the lung until your antibiotic will work or your management will work and the patient will recover. So in this, you want to just try to give the lung the maximum support you can, and with the same time, you don't want to cause any injury. Okay. You will ask me, so we are treating the patients and we're giving them treatment. So mechanical ventilation is the way to treat these patients. If you don't give mechanical ventilation to these patients, they will die, because they will die from hypoxia. So we have to ventilate these patients. But as everything in this life, nothing without side effects. Even paracetamol or aspirin will have side effects. Even the least of there's always side effects. Our role as physicians and critical care physicians is to try to minimize the side effects. So what are the adverse effects of positive pressure ventilation? Positive pressure ventilation. The main effects are 5. The first one is hemodynamic compromise. There might be barotrauma and volutrauma. Also oxygen toxicity and VQ mismatch. VQ is ventilation perfusion mismatch. And the need for sedation and use of drugs to keep the patient on during the ventilation period, sedation and neuromuscular blockers, and the ventilator-induced lung injury. So what is ventilator-associated lung injury? It is a definition as epithelial leaks from increased shear forces will lead to increased microvascular permeability. There will be surfactant deficiency and alveolar edema and the ARDS-like picture. So if I get a normal person, you and me, يعني بعد الشر عليكم, anyone, got a normal person and mechanically ventilate that person for more than 5 days, he will develop ARDS. He had normal lung, no infection, nothing. Just you ventilate these patients and for a long time, and they will develop ARDS-like picture. So mechanical ventilation can injure the lung. I'll explain how. The ventilator-associated lung injury, they have 3 major mechanisms. The collapse and reopen at if you give too low tidal volume. But if you also give too much tidal volume, you have excessive stretch, and this excessive stretch can put stress on the endothelium of the lung, and this can release cytokines and cause ventilator-associated lung injury. Also, the open and close, this shear force is open and close. This also can injure the epithelial lining of the lungs. Both of them. So at the lower end and at the upper end of this curve can cause injury of the lung and release of cytokines, and these cytokines can lead to ARDS-like picture. So we need to keep our ventilation in this area. We need to keep breathe in this area, not too low, not very high. So the understanding of pathology is very important, because in RDS you have an area which you have the disease. So this area has the pathology and disease, and also there's an area of atelectasis, and the rest of the lung is called the baby lung. So actually you think you are ventilating an adult person. Yes, you are ventilating another person. I'm sure we do that, but this lung of this adult person is part of it has been inflamed and infected. So what is left for healthy lung is like maybe 1/3 of the lung. So 1/3 of the lung is the lung we are ventilating. So we're not ventilating the whole lung as we ventilate normal people. We are ventilating only what is left from the lung, the healthy part of the lung. So if you give the same volume, you give it to a normal person. For example, if you come background anesthesia, and you give the same volume, you give it to normal lung people, and you give the same volume to a patient who have ARDS, you are over ventilating this lung. So you have to understand you are ventilating a baby lung. So the lung is a baby lung, as if of a lung of a baby in a big man, in a big patient. Okay, so a baby lung. So you have to modify your ventilator to give tidal volume to a baby tidal volume. You have to give a small tidal volumes. Okay, that's very important. And when you say compressive atelectasis, this is the area of the atelectasis, which is the collapsed alveoli at the back of the lung. And cyclic atelectasis when you have the open enclosure. When you have open closure, the area in between called compressive atelectasis. And the aim of the ventilator is to try also, in addition to ventilate the baby lung, try to recruit mean get this atelectatic part of the lung, try to open up in order to increase the amount of alveoli you can ventilate. So we try to make this baby lung maybe a teenager lung, if you can say. So instead of baby lung, you want to make it a bit larger part, so you can ventilate this lung by trying to open up this area of compressive atelectasis and cyclic atelectasis. So we do this what called protective or open lung ventilation. So we do open lung or protective lung ventilation. And the whole strategy is to try to reduce the ventilator-associated lung injury, to try to improve oxygenation. And by doing this, we improve the outcome from ARDS. ARDS outcome, in the beginning, mortality was between 50-60%. Now mortality is about 25 to 30%. How we reduced like half this mortality by doing this open lung strategy. So you can save lives. If you know how to ventilate patients on RDS, you can save lives. The same graph I told you. So you try to keep the tidal volume in this range between 4 and 8. Better to be 4 and 6. Try not to overstretch the alveoli by keeping the plateau pressure below 30, and try to prevent the collapse of the alveoli during expiration by giving PEEP. So this is the whole idea. Okay, so you give PEEP at the end of the expiration. So this is the PEEP. PEEP is called PEEP. It stands for positive end expiratory pressure. So the alveoli will not collapse. This is collapsed alveoli. So you need to keep the alveoli open at the end of expiration. You need to, when you give inspiration, you need to give enough inspiration to open the alveoli, but not to stretch the alveoli. So you need to keep your ventilation between these dotted lines. Here, this dotted line doing inspiration at the end of inspiration, and this will be at the end of expiration. You don't want this collapse, and you don't want to overstretch. You don't want this collapse, and you don't want to overstretch. I think it's obvious. Okay. So does this open lung strategy only in ICU? Not only in ICU. Even when you do anesthesia for a short time, even anesthesia for 2 hours, between 2 to 6 hours, you still have to use the open lung strategy. You still have to use low tidal volume. Don't overstretch. When I started doing anesthesia, maybe 30 years back, I used to give tidal volume 10 to 15 milliliter per kg. 1 liter of tidal volume with the norm. I mean, this is how I learned anesthesia in the beginning. I used to give 1 liter of tidal volume. This is absolutely wrong, because you can actually give the patient problems. You can increase the morbidity and mortality. This is Cochrane review, has been published in 2018, that if you use low tidal volume ventilation, even for short term, you will decrease the post-operative mortality, post-operative need for mechanical ventilation, post-operative length of stay, and post-operative lung injury. And this has been meta-analysis in a lot of clinical trials. So please, even if you don't do ICU and you do only anesthesia, use low tidal volume, use PEEP. Don't make PEEP 0. I know that you don't. Some people, I know some of my colleagues don't even look to the PEEP. They just ventilate, intubate the patient, put the patient on the ventilator, use 10 milliliter per kg. They don't look to the PEEP. They use 100% oxygen, FI200, and that's it, and get on with the rest. No, don't do this, because you will injure your patients. Okay, so please reduce your FI2 to just to keep the saturation above 95%. So maybe 30% FI2, not to cause oxygen toxicity. Put always PEEP, at least 5 of PEEP. Use 4 to 6 milliliter per kg tidal volume. This is the way to go. So open lung strategy, the most important is to deliver oxygen in order to avoid hypoxia. We allow permissive hypercapnia. So even if the CO2, I'm talking about now, of course, in ICU, we allow CO2 to rise. So we don't chase CO2. We don't follow CO2. We don't normalize CO2. Even if CO2 is high, we can allow CO2 to rise, as long as, because if you try to increase your minute ventilation to chase CO2 and to get it to normal, you will injure the lung. So and nobody in ICU dies from high CO2. But they will die from hypoxia, and also will die from ventilator-associated lung injury. So we try to keep the pH 7.3, but if the pH drops even to become acidotic respiratory acidosis to 7.15, we can accept that. So we will accept. I'll tell my nurses or the technician I will allow the as long as, so CO2 can go up to 50, 60, even 70 if my pH is above 7.15. Okay. Then if it touches 7.15, I might increase the minute ventilation or give sodium bicarb. But if my pH is above 7.15, I'm okay with it. So our aims from open lung strategy to prevent the opening and closure of the alveoli. So by this we avoid the atelectative trauma, limit the lung over distension. You remember the graph I've shown you. So so on the lower part of the graph, we prevent atelectative trauma and shear injury, this shear injury, and also we limit over distension. So we prevent volume trauma, and we also, by keeping the pressure below the possible airway pressure, we prevent barotrauma in form of surgical emphysema and tension pneumothorax. I remember when I was starting my training, I'm talking about 1991, 1992. One night I put 4 chest drains because I was in high pressure, high volumes, and this was a practice. And I was happy that I was good with chest drains, but of course this is not good for the patient. So don't do this, please. So the components that we have: low tidal volumes, 4 to 6 milliliter per kg. So we're talking about maybe 300, between 300 to 400 in females, and males we're talking about between 350 to 450. These are the range. We don't exceed that usually. Talking about low plateau pressure, so maximum 30, better to be below 30, even 27, and at least 5 of PEEP. Don't do ventilation with less than 5 of PEEP. When I say plateau pressure, people are confused. What is plateau pressure? Plateau pressure concept is very important. It's something you have to seek. You have to try to know. It will not come some ventilator will show it to you, but most ventilators, especially if you have a bit of old ventilator, would not give you the plateau pressure. What it gives you, it will give you airway pressure, and this airway pressure is the total pressure. Sometimes we call it peak inspiratory pressure. This total airway pressure is a sum of the whole pressure inside the thorax. So it will include the chest wall pressure, it will include the lung pressure, and includes the airway pressure. So it will include the airways, the pressure inside the airways. So if you have a patient who have asthma or a patient who have bronchoconstriction, it will include that. If the tube is kinked, it will include that. If the patient have also bad alveoli, it will include that. So it will include alveolar pressure, it will include airway pressure, and it will include the chest wall pressure. So all of this will give you the peak. So, but I need to know what is the alveolar pressure. This is the most important. When I saw the previous slide here, when I say a maximum plateau pressure 30, so it's not 30 of the total airway pressure. I'm talking about the alveolar pressure. How to know this? Is to do inspiratory hold. So you stop the flow at the end of inspiration. When the flow at the end of inspiration is 0, then the column of air between the alveoli and the pressure gauge will be static, and then you can measure the pressure now, and the pressure gauge will measure all of this because that column of air is not moving. You are measuring now the alveolar pressure. So the alveoli here will be measured by the pressure gauge. Okay, so you have to do what's called inspiratory hold. So you hold the flow, you stop the flow at the end of inspiration. When you stop at the end of inspiration and you wait for 2 seconds, then it will give you the pressure gauge will measure the plateau pressure. And if you have a kink tube, or if you have the patient have bronchoconstriction, you can see the difference here is high. So this one, for example, in this curve, you can see the peak difference. There's a big difference between the peak and the plateau. Why? Because in this patient, the patient has bronchoconstriction. If you have a patient who have ERDS, usually the plateau pressure will be here. The difference will be small. So the difference, how much, you can ask me what is the difference, usually is less than 5 centimeters of water. So if the peak pressure is, for example, 35, the plateau pressure will be 30. This is okay. But if you have patient have bronchoconstriction, for example, the plateau pressure can be 25 and his peak inspiratory pressure can be 60 because of that difference. Maybe he has tube kink, maybe the patient have bronchoconstriction. Okay. But what I'm interested in is this plateau pressure. That's very important. This article is very important. One of the few articles you have to know by heart. You don't work in ICU if you don't know this article, okay? Because this is one of the landmarks in ventilation. This is published in 4th of May 2000, and I'm sure that anyone who works in ICU know this article. Is just one of the few trials that shown improved mortality. One of the few in ICU that showed improved mortality. If you ventilate patient with lower tidal volume compared with traditional higher tidal volume in acute lung injury, they shown in this study that has been beneficial in mortality, morbidity, and mortality. And the study, it was more than 800 subjects, was stopped early because the survivor benefit. They found it is the benefit is so good that is even stopped early because it has been the advantage was very high. So the patient was treated with low tidal volume, have 31% mortality in patient, nearly 40% of, so nearly about 10% difference between And just by reducing tidal volume, it's just a small thing we do. Reduce tidal volume, you can see major change in mortality. And also here, look to this. There was decreased interleukin-6 levels. So this is there's an evidence that the reason for the decreased mortality is by decreased the interleukin-6, is one of the biomarkers for ventilator-associated lung injury. So the macrophage, I told you about the macrophage and inflammatory process when you do mechanical ventilation, was reduced by reducing the mechanical ventilation power. Okay, so the mortality is less. And you can see here the p-value is significant. 0.00, not only 0.007. And okay, so what they do, the trial was done by this group in Harvard, in Boston, in America. They call themselves ARDS Network. So ARDS Network, they did this ventilation strategy, and that's what we do in all ICU now. We calculate the predicted body weight. We don't calculate the actual body weight, we calculate the predicted body weight. Because you might have somebody who's 200 kilograms, but most of his body is due to weight is due to fat. So, and the lung is not, his lung will be at the same person who thin, but with the same, skeleton. But this fat is not good. So we do predicted body weight. What we need for predicted body weight, we need the gender, is it male or female, and we need the height. That's the only thing we need, and we have a table for that. We have some calculation, but I'm not going to bother you with calculation. Just you can go and Google. If you just put in the Google predicted body weight, ARDS net, it will give you the table. I'll just show you the table now. Also, you have to select the ventilator mode. We'll start usually with volume control, then we can change to pressure control later. Then the tidal volume has to be maximum of 6 milliliter per kg. Then you set the respiratory rate to optimize the minute ventilation. Usually, we try to aim for minute ventilation of 100 milliliter per kg per minute, and we divide this by 6. So we're talking about respiratory rate between 20 to 30. So we'll start with 20. I usually start with 20, then I will modify later. We accept CO2 between 88 to 95. And PO2 between 55 to 80, just to reduce the oxygen toxicity. We have also a table between the PEEP and FI2. So if you have, if the patient need a very high FI2, you need to increase the PEEP. So the patient is severely hypoxic and you need to give him very high FI2, then you have to increase the PEEP. There's a table also I'm going to show. Also, you can Google this table, very easy to Google. Just put ARDS net PEEP table, it will come to you. You try to plateau pressure. I explain what is plateau pressure. The plateau pressure is the alveolar pressure. So alveolar pressure, you have to keep below 30. Okay. The IE ratio, the inspiration to expiration ratio, we start with 1 to 2, normal 1 to 2, but we can change this IE ratio to make it equal to 1 to 1. The whole idea of that to increase the inspiratory time. When you increase the inspiratory time, you allow for because some alveoli, as I told you, is diseased. So when you have diseased alveoli, it will take longer to open. So when you do a longer inspiratory time, you give chance for this alveoli to open, and by this you recruit more alveoli. So you can actually do recruitment by increasing the inspiratory time. Sometimes even we do inverse ratio. So we inverse in severely hypoxic patients, can do even 2 to 1. So make it inverse ratio. So inspiration will be more than expiration. This is the predicted body weight and tidal volume for females, and this is for males. And this is the volume for 4 milliliter per kg, 6 milliliter, 5 milliliter per kg, So, for example, in an average female, we're talking about 320 for 5 and 380 for tidal volume. For average male, we're talking about here about 430, 440, 6 milliliter. So you don't go for higher than that. So this is what we're talking about. As I told you, anything between 300 to 450. So it's for males, of course. For females, we're talking about maybe 250 to 380 or even maximum 400. We don't exceed that. Of course, this is very long, very big females. We don't have. Okay. So we talked about the volume. So the volume has to be low, between 4 to 6. What about plateau pressure? So plateau pressure will not exceed 30. Better not to exceed 28. Okay. Also, permissive hypercapnia is okay. We accept that because when you have low tidal volume, you will have low minute ventilation. So you have accumulation of CO2. We can accept that, as I told you, as long as the pH is more than 7.15. I know some people say more than 7.2. Yes, we aim more than 7.2, but I'm saying that you can accept. I'm not asking you to ventilate all patients with acidotic. I'm saying if the patient is severe ARDS, you can accept up to 7.15. But of course, we aim for normal pH as much as we can. But if you are forced to do that, you can accept permissive hypercapnia. This is just to show you in this study, the study I showed you before in the ARDSNet trial, when is the mortality. So you can see here, this is in the high volume and in the low volume. And if you put them together, the two curves together, it will touch here. So we're talking about here, the start separation of mortality and like between 26 to 28. So we don't exceed that. Once you exceed that, the mortality will shoot up. Okay. So we try here to not to exceed mean plateau pressure in day one more than 26, 28 maximum. Don't exceed that. So try to keep plateau pressure below 28. PEEP. PEEP is very important. So as I told you, PEEP is positive inter-expiratory pressure, and there's also this study has shown that when you apply PEEP, you have better mortality. So you have mortality benefit, you have better survival for the patients, and this was good, is highly significant from this meta-analysis. So this meta-analysis, a lot of studies has shown that when you use PEEP, so it's not only a good theoretical concept. This has been evidence. This evidence you have to apply PEEP. So when you apply PEEP, you can save lives. And this is the table I told you about. So this table, you can get it easily. Google it, very easy. The first thing will come to you. Just put PEEP table, just put FI2 PEEP table, ARDSNet, it will come to you. And this is the low PEEP table in patients who have not like viral pneumonia. Like we use this low PEEP table in patients who do not have a lot of patches, a lot of inflammation. So this use this low PEEP table like in COVID ARDS. But if you have a lot of bacterial pneumonia, primary ARDS pneumonia, then we'll go with the high PEEP table. Okay. And you can see, even if you use very low FI2, you need to keep at least 5 of PEEP. In a very high, if you need 100%, we'll go up to 18 of PEEP. So as I told you, when you increase the FI2, you have to increase your PEEP. So what is the value of PEEP? What is the physiological benefit of PEEP? PEEP cause recruitment. What do you mean recruitment? You increase your number of alveoli. And instead of you, for example, I'm just saying, do you remember the baby lung I told you about? So for example, if you, just to give you an example, if you have a million alveoli in each lung, and now you have disease of 2/3 of them, what is left is only 300,000 of alveoli. You need to increase this number from 300,000 to the best you can. For example, from 300 to 600,000. How to do this? By applying PEEP. Why PEEP can help recruit alveoli? Because in expiration, it will prevent collapse. And when prevent collapse, it will leave some pressure inside and it will prevent collapse. So the next ventilation, it will be open. Okay, it will by recruiting more alveoli, it will reduce shunt, because the less collapsed alveoli, the less shunt. Also, it will increase the functional residual capacity because you increase the number of alveoli, and it will improve oxygenation. So it's very important. If you have a child in your home and you want to make this child happy and inflate balloons, and when you have the balloon, when you have totally collapsed balloon, it's difficult to inflate. If you have some air in this balloon and you inflate, it's easier to inflate. Okay, so the mechanics of the breathing also is better when you do PEEP. So also PEEP prevent collapse and improve the mechanics of breathing. I don't know why it's not moving. Okay. So despite PEEP, somebody will say, oh, but you're giving positive pressure even. So you give positive pressure during inspiration and during expiration. You will expect the airway pressure to be higher, yes, but the mean pressure is lower. How can you explain that? So actually, the mean pressure inside the lungs will be lower. I tell you why. Because instead of you ventilating 300,000 alveoli, you are ventilating. So the pressure, instead of this pressure distributed between 300,000, this pressure is distributed now by double the number. So for the same pressure, instead of ventilating this small volume, you distribute the same pressure over a larger volume. So the whole mean would be less. You got the point? So when you use PEEP, you're recruiting more alveoli. So you're introducing more alveoli in the ventilation. When you recruit more alveoli, you increase the number of alveoli. So the whole total pressure around in the alveoli, the mean pressure all over the lungs will be less coming down. So the mean alveoli inside the lung, mean pressure, and this will help in reducing the injury in the lungs. Okay, now this is very important. Now this is not many people understand this. This is called transpulmonary pressure. What is transpulmonary pressure? This concept you have to understand. I try to make it as easy as I can. Is anyone, Dr. Safa, is anyone want me to speak in Arabic combined with English? I'm speak 100% English, but I can speak Arabic as well.
Yeah, we can do a mix. We have no foreigner, so we can do a mix in this area, especially in this area. You hear me, Dr. Yasser?
ايوه سامعك كويس. يعني اتكلم عربي شويه مش اشكال؟
شويه، وحضرتك بتقول لهم البريشرز والحاجات دي يا ريت، علشان احنا ما معناش الحمد لله فورينر خالص، كلهم يعني
طيب
اخواتنا.
انا اسف
لا خالص، اطلاقا هي بس الاريا ديت بالذات.
هل في حته كنت حسيت ان هي محتاجه ان انا اشرحها تاني؟
وهنا استاذنك برضو الفاليو اوف بيب اللي قبلها، السلايد اللي قبلها والسلايد دي، من فضل حضرتك اعملها ميكس كده، خليها تدخل في دماغهم كويس بعد اذنك.
طيب خلاص.
ميرسي لحضرتك يا دكتور ياسر، ميرسي لحضرتك.
دي واللي قبلها؟
السلايد اللي قبلها، البيب، من اول البيب كده
حضرتك. البيب. طيب خلاص.
اوكي.
ثانك يو. طيب اوكي، بسم الله. طيب ادي اول حاجه في البيب. طيب البيب احنا قلنا ان البيب ده اثبات، مش مجرد كلام شرح نظري. فكره كويسه، هو مش فكره كويسه وبس، هو طبعا فكره كويسه، بس قصدي هو كمان عليه اثبات علمي ان البيب مفيد، انه بيقلل المورتاليتي. فادي الايفيدنس. فانت لما تستخدم بيب you are helping patients and you reduce mortality in the patients. طيب ده اول حاجه. رقم 2، ده التيبل ان احنا بنجيبه ازاي؟ بنكتب جوجل، بنفتح جوجل ونكتب بس FiO2 بيب تيبل، هيطلع لنا ده. خلاص، ده اللو بيب تيبل، ده في لما يكونش الانفلاميشن عالي، زي مثلا الكوفيد مشكلته ما كانش اكتر انفلاماتوري، فممكن نستخدم اللو بيب تيبل. لما يكون في a lot of patches وبكتيريا و a lot of inflammation وكده، يستحسن تستخدم الهاي بيب تيبل. Thank you very much. Thank you. You are the best. Thank you. Okay. بكلم الناس بس. طيب خلاص، فلما يكون ممكن تستخدم هاي بيب تيبل. احنا قلنا ان at least you need to give at least 5 of PEEP. حتى لو FiO2 بتاعك at the minimum you need to keep at least 5 of PEEP. ليه؟ علشان prevent alveolar collapse، بيعمل الكوتن. ولو وصلنا 100% ممكن نوصل لغايه 18 PEEP. طبعا عمرنا ما بنوصل، بس يعني لو انت حبيت توصل لغايه 18 ماشي. يعني انا بوصل 15 يعني، ما عشان بس ممكن توصل 18 لو احتجت. هقول لك ازاي لو احتجت، دي هي اللي بقى هشرحها دلوقتي في الترانسبولمونري بريشر. ماشي. بس امتى لازم يكون يعني طبعا يمكن في مصر مش موجود موضوع الاكسجين بريشر ده، بس على الاقل هفهمه لكم، ولو قدرتوا تجيبوه يبقى كويس. طيب قلنا وكل ما نزود البيب، ده السلايد ده، كل ما نزود البيب كل ما نحتاج، يعني مثلا لو 70% نحط العيان على 10 بيب اتليست. كل ما نزود البيب كل ما نحتاج ان احنا نزود الايه البيب، اسف الاف اي 2، كل ما نزود الاف اي 2 كل ما نحتاج نزود البيب. كل ده واضح. طيب احنا قلنا ايه فائده البيب؟ وات ذا فيسيولوجي بيهايند ذا بيب؟ ان البيب بيركود. احنا قلنا ان العيان عنده انفلاميشن وعنده الار دي اس عباره عن باثولوجي، حصل انفلاميشن في اللنج، الالفلاي كلها مليانه انفلاماتوري فلويد، مليانه انفلاميشن، فالجزء اللي فاضل هيلثي جزء بسيط. هو ده اللي احنا بنعمله فنتليشن. انا محتاج ازود، لان الطريقه الوحيده ان انا اعمل عيان ده اوكسجينيشن، ادخل اكسجين جوه الدم، ان انا اعمل له فنتليشن للهيلثي الفلاي. طب بقيه الالفلاي دول جزء منها مليان فلويد مش هقدر اتصرف فيه، خلاص ده محتاج ان انا اصبر عليه لغايه لما يخف بالانتيبيوتكس. الجزء في جزء وسط ده مقفول بين الجزء الديزيزد والجزء الهيلثي، ده متداس عليه، ده مقفول. فانا ازاي افتحه؟ انا لو اديت بيب ات ذا اند، يعني بريشر ات ذا اند اوف اكسبيريشن، البريشر ده هيتغلغل في الالفلاي دي اللي هي كولابس، ويفتحها لي تك 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 تك، يقعد يفتحها كده. خلاص. فلما يفتحها لي، بدل ما كنت انا فنتليت تلت اللنج، هفنتليت تلتين اللنج، والتلت اللي مقفول ده اوريدي بالانفلاماتوري خلاص انا مستنيه لغايه لما يتحسن ان شاء الله. فانا محتاج البيب ده عشان يوبن اب الالفلاي. بدل ما الالفلاي ات ذا اند اوف اكسبيريشن تقفل، لا انا اخلي فيها شويه هواء فتفتح لي الالفلاي المقفله. فده هدف البيب، ان انا prevent collapse at the end of expiration. When you prevent collapse you are recruiting alveoli. By recruiting alveoli بتدخل alveoli معايا، بدل ما كنا 300,000 بقينا 600,000، بقى نقلل الشنط. يعني ايه شنط؟ ان انا البلاد يعدي من الدي اوكسجينيتد للاكسجينيتد ما يشوفش اكسجين خالص، لان الالفلاي مقفوله. لما افتح له الفلاي هيشوف الاكسجين ويتعامل معاه، فيخش الاكسجين جوه الدم. يبقى انا بقلل الشنط. خلاص. بزود الفانكشن ريزيدوال كاباسيتي، لان كان عندي الفانكشن ريزيدوال كاباسيتي كانت قليله. ليه؟ عشان ما كانش فيه الفلاي. لما فتح لي الفلاي هزود الفانكشن ريزيدوال كاباسيتي اند ذا اند اوف اكسبيريشن طبعا. with improve oxygenation. طبعا كل الهدف ان انا لما ازود عدد الفلاي احسن oxygenation of the patient. واضحه؟ دي سهله تقريبا. طيب موضوع المين بريشر. المين بريشر ده مهم في ايه؟ المين بريشر ده هو اللي بينشا من الفنتليشن. انا دلوقتي بدخل الفنتليتور ده عباره عن منفاخ، بدخل بوست بريشر انسايد ذا لانج. خلاص. كل ما ازود البوست بريشر ده مش حاجه حلوه على اللانج، كل ما اقلل البوست بريشر دي حاجه كويسه. طيب ازاي اقلل البوست بريشر؟ لما اعمل بيب. ليه بقى؟ لما انا زي ما فهمتكم السلايد اللي قبل كده، انا دلوقتي زودت عدد الالفلاي، بدل ما كان البريشر متوزع على 300,000 هيتوزع على 600,000. نفس البريشر ده. خلاص. بدل ما كان، تخيل انت عندك كوره صغيره وحاطط فيها نفس كم البريشر، لو كبرت الكوره دي، البريشر ده بدل ما كان يتحط في الكوره الصغيره ومزنوق قوي في الكوره الصغيره، هيتحط في الكوره الكبيره. هيتحط الكوره الكبيره هيتوزع في الكوره الكبيره، فلو قست في الكوره الكبيره هتلاقيه البريشر قل. خلاص. بدل ما كان البريشر مزنوق، بدل ما كنت زنقه في البيبي لانج، كبرت اللانج اللي هو محطوط فيه البريشر، فالبريشر اللي انا بديه، اللي انا قاعد انفخ بيه البوست بريشر ده، بدل ما كان في سمول اريا، بدل ما كان في سمول 300,000 الفلاي، بقى في 600,000، فتوزع عليهم، فتلاقي المين بتاعها يقل. خلاص. فتلاقي المين بريشر، لو انا قست، لو قست المين بتاع جوه الالفلاي كلها، تلاقي المين قل. مع اني البوست بريشر ده انا اديت بريشر في الانسبيريشن واكسبيريشن، بس انا اديت لما اديت البريشر ده انا وزعته، بدل ما كان محطوط في 300,000 انا فتحت 300,000 تانيين فتوزع عليهم، فبقى المين المتوسط بقى احسن. مفهومه دي ولا مش مفهومه؟ اتفهمت كده ولا اعيدها تاني؟
تمام دكتور ياسر، انت هيبقى على حضرتك عبء، لان للاسف انا غلطت في حاجه، ان كان عندنا ناس فعلا فورينر. سهيل جمعه is our colleague from Kenya, and he left the lecture, and when I asked him why Suhail, you started to speak in Arabic and I don't understand anything. So I'm very sorry. I'm very sorry, Suhail. I'm very sorry, Professor Yasser.
Okay, so should I go back?
Yeah.
I'll go back to English, yeah?
Yeah.
Okay.
Thank you.
Okay. So this is what, okay. So now, this is another concept called transpulmonary pressure. Transpulmonary pressure is very important, ya shabab. Very important to understand. Transpulmonary pressure is a pressure between the, هو ده اللي هو البريشر من الالفيولاي to the pleura. As the name say, transpulmonary. Why it is important? Because transpulmonary pressure is the pressure to make the alveoli open. So when you apply a pressure, I told you that ventilator will apply pressure. If that pressure is above, if the pressure gradient is above what is inside the alveoli, it will make the alveoli open. Easy. So you have to give enough positive pressure, more than the alveolar pressure, in order to open it during inspiration. During expiration, you have the PEEP. You apply PEEP. And this PEEP is to prevent alveolar collapse. But what happens if your PEEP is lower than the alveolar pressure at the end of expiration? It will collapse. So you need to adjust your PEEP at the end of expiration more than the pressure. Otherwise, the pressure the end expiratory pressure will close the alveoli despite your PEEP. This is how to adjust your PEEP. So you need to adjust your PEEP above the transpulmonary pressure at the end of expiration. How to do that? We put this probe. Can you see this NG tube? It's like NG tube, and P is pressure, ES mean esophagus. So esophageal pressure. There's a lot of study to show that if you put a pressure gauge, مقاس, pressure gauge at mid-esophagus, it will reflect the pleural pressure. خلاص? So we take this as an estimate. So pleural pressure roughly equal the esophageal pressure. خلاص? Okay? So now, changes of esophageal pressure closely correlate with changes on pleural pressure, allowing to estimate transpulmonary pressure at the difference between the alveolar pressure and esophageal pressure. So transpulmonary pressure equal alveolar pressure minus pleural pressure. اللي هو ده. So this pressure is between the pressure in the pleura. This is the pleura. This is the pleura, called the pleura. Okay, and the alveolar pressure. Or because we can't measure the pleural pressure, we cannot put a probe inside the pleura. If you put a probe inside the pleura, you cause pneumothorax. So we can, instead of that, we can put esophageal probe inside the esophagus. In the mid-esophagus, it will give us the number, of pressure, and this number will be the pleural pressure. So if you subtract, if you subtract esophageal pressure, if you take from the pleural pressure, it will give you the transpulmonary pressure. It has to be positive in inspiration and expiration. If it is negative, either in inspiration or expiration, you're not ventilating the lung. You have to have positive transpulmonary pressure during inspiration in order to inflate the lung. And in expiration, you have to have also positive transpulmonary pressure, because if you have negative, it will collapse. The alveoli will collapse. You have to have positive pressure inside the alveoli during expiration. Otherwise, the alveoli will collapse. You need to have some positive pressure during expiration. And of course, during expiration, because you have positive pressure, because inspiration is active, you're giving pressure, during expiration, it will inflate the lung. The problem is during expiration, because if you don't have enough PEEP, if your PEEP is below the pleural pressure, is below the esophageal pressure, you will have collapse. I'm going to explain this to you. So Look here to expiration. Okay, this end expiratory pulmonary pressure. If you PEEP, for example, if you put your patient PEEP 5, okay, so for example, you have FI2, you go by the table, the table I showed you, and for example, you have FI2 of 30%. So you put your people as the table told you, you put at 5, خلاص, okay. But you put your esophageal pressure and you measure your pleural pressure at the end of expiration come as 8. So you actually have -3. So your PEEP is not enough to overcome the pleural pressure. So your alveoli at the end of expiration will collapse, despite you have PEEP. So what you need to do, you need to increase your PEEP above your transpulmonary pressure. Okay? So when you increase your PEEP above your transpulmonary pressure, you have some pressure inside the alveoli, so your alveoli will not open, will not close. So it will keep open at the end of expiration. So this is the value of your transpulmonary pressure because you put esophageal pressure. I know that not many people use esophageal pressure, but if you have it, it will improve your morbidity and mortality. I'm going to show you a study that mortality has been reduced a lot when people use esophageal pressure, because you can calculate transpulmonary pressure and you can calculate transpulmonary pressure during expiration. And by calculating transpulmonary pressure during expiration, and you put your PEEP above that level, you can reduce the end expiratory collapse of alveoli. So, read this. Adequate PEEP level can prevent alveolar collapse and reopening injury, atelectasis trauma, which might be avoided by keeping the transpulmonary pressure. Always keep the transpulmonary pressure by use of esophageal pressure monitoring. If you use esophageal pressure monitoring, you can always keep the PEEP on the PEEP higher than transpulmonary pressure in order to keep the alveoli open at the end of expiration. The extreme example, this example, I'm just giving you this example in a patient who's obese and he have RDS. Look here, this is the pressure gauge. This is the pressure measurement. During expiration is fine. Plateau pressure is 30. You put the PEEP as 22. He's on 100% oxygen. So in 100% oxygen, you put PEEP 22. This is يعني very high PEEP. This is very high PEEP. يعني you have to be very brave to put 22. خلاص? 22 PEEP, and you think your PEEP is good. Oh, I'm very good. I put PEEP as 22. But look, during expiration is okay, because during expiration, this is esophageal pressure. PES, I mean during expiration, PES, esophageal pressure during expiration. Okay, so this is esophageal pressure during expiration is 28, and you put your plateau at 30. So there's 2 centimeter difference. It will have some of inspiration. So you will have positive pressure in inspiration about 2. At least you have some air go inside. You have small tidal volume, but at least you go some air. Look, during expiration. Expiration of esophageal pressure is 26. So during expiration, you have actually is less than the esophageal pressure is higher than the plateau pressure, than the PEEP. So the PEEP is less, the 22 you're giving is less than esophageal pressure, is less than pleural pressure. So what's happening now? Collapse. Despite I'm giving PEEP at 22, and I think that PEEP is enough for me to keep the alveoli open during expiration, but I'm not. Actually, by using esophageal pressure, I know now that my pleural pressure is 26, so I have to put the PEEP higher. So what I have done, I increase my PEEP. But because I increase my PEEP, I cannot also keep my plateau pressure at 30. I have also to increase my plateau pressure. So I increase my plateau pressure now to 33 in order to have some driving pressure, because the driving pressure is the difference between plateau and PEEP. So you need at least 6 of driving pressure. So I increase my plateau to 33 instead of 30. So I have positive pressure during inspiration, and in expiration, my PEEP is 27 now, so is more. I have 1 centimeter above the than esophageal pressure. So my oscillatory pressure is the same. So as doing inspiration is 26, 28, the same. Expiration 26. But what I have done, I increased my PEEP to 27 instead of 22. So I'm above my expiratory oscillatory pressure. And also I increased my plateau from 30 to 33 in order to have driving pressure. So now I have five of difference doing inspiration. So I'm inflating the lung with 5 of pressure, doing inspiration, and doing expiration. My lung is not collapsed because at least I have my PEEP is above my oscillatory pressure. Of course, this is extreme example. I'm not saying this you have to do in every patient, but I'm saying this is extreme. But the reason I showed you this extreme example is because to understand that transpulmonary pressure. We don't use oscillatory pressure in most of the cases, but this is something you can think about. If you still use PEEP and you still have hypoxia, you might need to increase the PEEP gradually by 1 or 2 centimeters until you get to achieve better oxygenation. I hope you understand this. This is the study I told you about, that 28-day mortality by using oscillatory pressure. When you use oscillatory pressure in the oscillatory pressure group, when they use, this is Talmor. Talmor is one of the famous people from the RDS network. He published in New England Journal, and when he used oscillatory pressure, he can reduce mortality from 39% to 17%. Can you imagine? You are, by using this conventional treatment without oscillatory pressure, when you use oscillatory pressure, you can guide your PEEP and you can guide your inspiratory pressure, and he can modify the PEEP table according to the transpulmonary pressure. So transpulmonary pressure is very important concept. Not many people understand it, but I hope you understand it now. And the way to apply it is when you use oscillatory pressure monitoring. Okay, now we go to driving pressure. Driving pressure is very also important concept. Driving pressure, or sometimes we call it tidal pressure. This is also, you have to understand this. Very easy to understand, but also is something you need to apply in your everyday practice. There's a lot of studies have shown that when you use driving pressure, you minimize driving pressure, you can reduce mortality. So mortality can be, so you have a mortality benefit as well when you reduce your driving pressure. This study is the first one in Amato. There's also other studies, but Amato study was the landmark study to show that driving pressure is important in reducing mortality. So what he did, he reduced the tidal pressure. And we need to understand first what is driving pressure or tidal pressure. Tidal pressure or driving pressure is the difference between the plateau pressure during inspiration and the PEEP. Okay, so if you have, for example, a plateau pressure of 25 and you have PEEP of 15, so the driving pressure is the difference between both. So it's 10. So when I have plateau pressure of 25 and I have my PEEP at 15, so the driving pressure is 10. If I have my plateau pressure as 25 and I have my PEEP at 10, so the difference is 15, so my driving pressure is 15. So it goes with the compliance. So when you have better compliance, you don't need high driving pressure because the lung is compliant. So you don't need high pressure to inflate it. Okay, so when you have lower driving pressure, you mean that your compliance is better. Hello? Sorry? Anybody talking? Okay. So
No, Dr. Yasser, تفضل, مفيش حاجة.
Okay. So when you have a lower driving pressure, mean that the lung is less stiff. When you have stiff lung or less compliant lung, you need the higher driving pressure. Okay. So now we understand what's diving pressure. Diving pressure is the difference between plateau and PEEP. Diving pressure, we always put as delta pressure. Sometimes we call it delta pressure. Sometimes we call it tidal pressure. Anyway, so delta pressure or diving pressure is an accurate index of cycle lung strain. And the lower the diving pressure, the better the outcome. So Amato in 2015 done retrospective analysis of thousands of patients. Amato works in Brazil, but he's one of the godfathers of ARDS as well. So he did this retrospective study in all his patients in Brazil, and he find this. He could create about 3,500 patients, and he find this 9 major studies, and he find that diving pressure with a better predictive mortality. Okay, and this is his original study, and this is the summary or the conclusion. You can see when you have a higher, so when you have a rising delta pressure, yeah, by so we said the delta pressure is when حاصل طرح البيب minus البيب plateau. خلاص plateau pressure. So when you have a higher tidal pressure, means you have a high plateau with the same PEEP, you have high mortality. Also, when you have if you have high plateau pressure and high PEEP, so the difference is the same, you have same mortality. But look to this, when you have same plateau and higher PEEP, you have less tidal pressure, you have less mortality. So if you want to have lower your mortality, you have to reduce your diving pressure. So you tell me, Dr. Tolba, tell me the magic number. The magic number is here. I'm not going to through this. It's the same slide I just showed you. So 14 to 15. So you have increased risk of death when your plateau pressure is above 14 or 15. We can allow up to 18, but better to be below 14 to 15. So you need to keep the difference between your plateau and PEEP. You have to keep it below 14 to 15 centimeter water. Okay. If you have higher pressure difference, you are asking for trouble. You can increase mortality of your patients. So you have to reduce your plateau. You have to increase your PEEP to keep the difference between 14 to 15. By this way, you can reduce the mortality of your patients. And this is also from Amato. You can see the mortality will increase risk of death will be higher when you go above 15. See here, 15 above this, shoot up, shoots, pew, go up. So you need to keep your diving here pressure between 5 to 15. Okay, centimeter water, of course. This also other studies. In this study, it show below 18. I told you we can accept up to 18, but below 15 is better. Okay, so diving pressure, we understand now diving pressure target below 15. Okay, stress index, I think is beyond you now, but I'm not going through this because I think you need more attention. I think now we are more than 1 hour now, 1 hour, 20 minutes, but that's enough. Anyway, so go here. We try to keep our plateau. So our aim in our modern, I told you, ventilation strategy in 21st century, we need to keep plateau below 29 as much as we can. We need to keep our tidal volume between 4 to 6. This is important. Okay. This mechanical power. Mechanical power, people talk about a lot of mechanical power these days. It's a new concept. For you, I'm not going to expand on this. I can give you a full lecture about it, but I can tell you now, the less mechanical power, the better the outcome. It has this calculation, but you can get you from calculation the respiratory rate. Okay, it includes all the component of mechanical ventilation, but this component is very important, the respiratory rate, because I know that people try to compensate for to increase the minute ventilation by increasing respiratory rate. I've seen people go to 35 of respiratory rate, which has been acceptable before, because you keep your tidal volume, the maximum you can go to 6, you increase your respiratory rate to 35 in order to achieve minute ventilation enough to clear the CO2. I'd advise you against that. I will increase my respiratory rate, but I never exceed 30. In my practice, I never, because when you increase the respiratory rate, you increase the mechanical power. And a lot of studies have shown now that ventilated associated lung injury, it depends on the, and ERDS changes increase mechanical power. And you can see here, respiratory rate is one of the major determinants of mechanical power. Also, one of other major determinants, the delta pressure, the delta volume. So volume here, tidal volume, delta pressure, PEEP, and respiratory rate. So these are the determinants of mechanical power. The less mechanical power, the less amount of mechanical ventilation you give to the patients, the less ventilated associated lung injury. How to do this? Less volume and less respiratory rate. Because I know that some of you will try to compensate for low tidal volume by increasing the rate. I advise you against that. You can do this. Of course, you have to increase the rate, but don't exceed 30. Okay. So here to say this is mortality. When you increase the mechanical power, you have higher mortality. Okay. So we'll try, as I told you, this is a collection of what we have to do. Decrease our plateau pressure, limit your respiratory rate. I told you, limit your respiratory rate, and try to set the PEEP according to the transpulmonary pressure. According to transpulmonary pressure. By this, you are, before we go into the next subject about neuromuscular blocking, by doing this, you are achieving a good mechanical ventilation. Try to reduce your plateau pressure, try to reduce your tidal volume, try to reduce your respiratory rate. I know that you cannot reduce as much, but don't exceed 30. Try to adjust your PEEP according to esophageal pressure, according to the pleural pressure, according to the transpulmonary pressure. By doing this, you are doing good for your patients, you reduce your mortality. Now we talk about neuromuscular blockers. Neuromuscular blockers has been shown that to reduce mortality from ARDS. It also has been said that when you use a patient spontaneous breathing and patient on muscle paralysis, and you can see the lung injury here. You can see the lung injury in patients who are when the spontaneous breathing not having so when you paralyze the patient, you have less lung injury. This has been advocated. So it has been advocated that neuromuscular blockers bind to nicotinic receptor neuromuscular junction, and it can exert pro-inflammatory properties, promote the lung neutrophilic activation, and neuromuscular blockers. The hypothesis, it's protective against ventilated lung injury because of the anti-inflammatory effects. And has been shown that in some studies that in Aquarius trial that showed statistically significant reduction in mortality in patients on moderate to severe RDS. It has to be, of course, moderate to severe when you use cis-artechoria compared with people who have sedated without artechoria. So it has been weakly recommended, but this unfortunately has been challenged by the Rose trial. This Rose trial has challenged the Aquarius trial. So Rose trial has shown that no difference between the intervention group, which is given the neuromuscular blocker, and the control group, which did not have neuromuscular blocker. Mortality was the same, 42% in both. Remember, this is severe ARDS because the mortality here is very high, 42 to 42. So it is a randomized control trial with the intention to treat analysis. So it has put a lot of shadows on the Aquarius trial. Now it's not recommended to use neuromuscular blockers, but I would advise you in the early phase when you have severe hypoxia and when you have patients are difficult to ventilate, I still use neuromuscular blockers because of the benefits, but I don't continue with it because, as we all know, it can contribute to the critical care myopathy, as we all know, when you use long-term muscle paralysis. So in the initial phase, maybe in the first 2 days, I would use neuromuscular blockers, but I don't exceed that. I don't do that. This is my verdict from the debate between neuromuscular, should I use it or not? Okay. That's enough for that. Then we go for prone position. Prone position is one of the established methods when we ventilate patients in ARDS, and I advise you to use it more and more. I know a lot of units don't use it. I don't know why. It is a very effective way of reducing mortality, and it's physiological way. And when you use it, you can find you are improving your mortality in your unit a lot. But you need to know how to use it. So what is the value of it? It improves the VQ matching. So as we all know that in RDS we have VQ mismatching. There's areas of the lungs which does not receive oxygen and shunt. Hello, yes. So you have areas of the lungs which does not receive enough oxygen because the shunt, and also there's over ventilated areas which do not receive perfusion. So there's dead space areas and there's shunt areas, and in between they have mismatch. So this has been proposed by Gattinoni long time ago, but unfortunately Gattinoni did not show mortality benefit. It showed improved oxygenation but not mortality benefit until a recent trial, clinical trial, ProSiva trial, have shown mortality benefit, and now it's a standard of care in a lot of ventilated patients. So the idea of prone ventilation, it increases the functional residual capacity, reduce atelectasis, improve secretion drainage, and less lung deformation in prone position, because you take the weight of the heart on the lungs. Because when in supine, you have the weight of the heart pressing on the lungs. When you go prone, the weight of the heart go against the sternum. So, okay, so this is this, of course, the patient is ventilated upright. This is the patient. This, remember from physiology, west lung zones from physiology. Whoever did physiology, it's a long time ago. This is west lung zones. This is when the patient is upright. The upper lung, you have more ventilation than perfusion. In the lower lung zone, with the gravity, you have more perfusion than ventilation. In the mid lung zone, you have equal. And this, when the patient is supine, the upper lung zone will be here. This is the mid lung zone, and this is the lower lung zone. You can see here the patient is have ARDS, and this is CT chest during patient ARDS, and you can see here this is the upper lung zone, this is the mid lung zone, and this is the lower lung zone. Okay, what we do here is try to prone the position. Okay, so this is supine. The goal prone position is to improve VQ mismatching. So you can see here you will have over distended lungs. You have here the area which you have the middle lung zone is filled, is affected, and also lower lung zone. So we need to ventilate this area. How to do this? I'm going to show you. So you can see here, look to the vertebral column. These two patients are supine. These two patients are prone position. You can see here in the supine, you can see all the fluid, inflammatory fluid accumulating in because of gravity in the lower lungs wall. Here, when you do prone position, the heart moves away from the lungs. So the heart will come here again as a sternum. You can see here the areas of the lung which has not been ventilated before will have now oxygen. And because of the anatomy of the lung, you can see here the bases of the lung are larger than the tip of the lung. So the tip of the lung is like pyramid. Yes, it's like pyramid. We are Egyptians, we have pyramids. Yes, so you can, the base of the lung is a lot of alveoli are in the base, and the minority of alveoli in the top of the pyramid. Okay, so when you do prone position, you ventilate more alveoli. So you are ventilating more, the bases of the lung now become ventilated, so you have more recruitment. Do you remember the recruitment? I told you the 300 and 600,000. So instead of here ventilating only 300,000, now you're ventilating 600,000. So you are ventilating more lung alveoli when you do prone position. Here also the same. Also, you ventilate more lung alveoli. You can see the difference. Okay. So this is how to explain. So same as I told you. So more homogeneous ventilation happens, reduce the difference between the dorsal, I mean the back, and the ventral, and the ventral, the anterior part of the pleural pressure. It will reduce the driving pressure. Why reduce the driving pressure? I told you this before. Instead of ventilating 300,000, the pressure will be distributed all over 600,000. So instead of you ventilating a small part of the lung, you ventilate a larger part of the lung. So the pressure will be distributed all over this larger part. So the driving pressure will be reduced. And I told you before, I showed you Amato study. Amato study have shown that when you reduce the driving pressure, you are reducing the mortality. So here you can see the transpulmonary pressure also reduced. Imagine here, supine pressure, transpulmonary pressure during inspiration, very high. When you do prone position, the transpulmonary pressure will be reduced. Do you remember transpulmonary pressure? I told you transpulmonary pressure will be reduced. So it reduces also atelectasis, reduce atelectative trauma. So the open and closure of alveoli will be reduced because you have more recruitment of alveoli. Okay. So the prone position will reduce myovolute trauma, reduce atelectative trauma, okay? And we have more homogeneous. When you have prone position, you have more homogeneous ventilation. And this is the study I've shown you. So it's not only the concept. Now the concept is evidenced by study. And this has been one of the also landmarks in ICU PROSEVA trial. PROSEVA trial is published in New England Journal in 2013. And it hypothesized that if you have early application or prolonged, you have to be early. The previous prone studies did not show mortality benefits because of this. Has been done in a shorter period and also done as a rescue treatment. Rescue means at the end of your treatment ladder. So you prone position after 1 week of ARDS ventilation. No, it will not work. You have to use it early in the first 18 to 24 hours. So you have to be early application and you have to be prolonged. What do you mean prolonged? At least 16 to 18 hours. More than 18 hours. So most of the day, the patient will spend proning. Only will be supine between 4 to 6 hours maximum. Okay? The less time supine, the better. The more time prone, the better. And has been shown that reduced 28 and 90-day mortality in patients with severe RDS. It will, this is the old studies. The old studies has improved oxygenation, but not mortality benefit because has been applied late and also a short period. But with this study has been applied early and long, And you can see here, impressive, very impressive mortality benefit. In 28 mortality reduced from 32% to 16%. And 90-day mortality, the mortality benefit will last from 41% to 23%. By just changing the position. So it's very, very important. Please do in your ICU. You can save lives by doing prone position. Of course, there's more responders and non-responders. In the responders group, you can have survival benefit if you apply prone position. So PROCEIVA trial showed a marked mortality benefit. Number needed to treat is very good, 6 in prone ventilation, and mortality benefit, as I told you, 16% versus 32%. So it prevent ventilator-associated lung injury. And what are the indications? So not every patient ARDS we apply, despite it helping everyone, but I'm talking about the mortality benefit. We use it for severe RDS. So if your PF ratio, the PO2 in the blood, PO2 over FiO2 ratio is less than 150 millimeter mercury or 20 kilopascal, with FiO2 more than 60%, and PEEP above, you can apply early prone position. So in the first, okay, so at least 16 hours per day. So if you have your patient, you intubate the patient, ventilate the patient, and I do a blood gas. My blood gas, I calculate the PF ratio. If my PF ratio if my FiO2 is above 60%, mean severe RDS, my PEEP is above 5, means also severe RDS. I calculate my PF ratio. If it comes as less than 150, mean also severe RDS, I start boning. So I start boning my first day. In first few hours, I ask the patient to be boned. I keep it for at least 16 hours per day. Okay, I continue for how long? You can ask Dr. Tolba, how long? A week or 2? No. Each day I do supine and do blood gas and see. If my blood gas improves from above 150, okay, that's fine. If it's still below 150, I bone second day, third day, okay, until I got a consistent improvement on my BF ratio. Then I will stop boning. Maybe need 3 days of boning, 4 days of boning. So I've been in my patients in my ICU. Sometimes I do it 3 days, 4 days, 1 week. Then, but I have to see improvement. If I don't see improvement, this means the boning is not working. So as I told you, must be done, bone early and prolonged period. And complication rate is low if you do proper training. If you do proper training of your ICU staff, you have less problems. And use of a bundle therapy. So what do you mean use of bundle therapy? I'll tell you what I mean by this. You ventilate your patients, you do early boning. If your early boning does not work, you do ECMO. Okay? Of course, you need to have a center who have ECMO. I don't know about Egypt, but I think there's some centers which have ECMO. I know this. So if your ventilation doesn't work, if you have severe RDS, I'm talking, of course, about severe RDS, very severe RDS. You apply ventilation, you apply protective lung strategy. Doesn't work, I do early boning. If it doesn't work, then I go for ECMO. By this, I prevent ventilator-associated lung injury and improve mortality. This is what we use in our unit. So we have low threshold. We start with protective lung ventilation. We have low threshold to start boning. If the boning doesn't work, then we ask the ECMO team to come and put the patient on ECMO. So when to use ECMO? With ECMO in failed boning. So which patient should I put in ECMO? In failed boning, because the mortality benefit from boning is very good, from 32 to 16%. So 16% if I do boning. But if I don't have this boning benefit, I have to go for ECMO. So after 1 hour of bone ventilation, portion are classified into responders and non-responders. The responders of bone position, then I will continue with boning. If my severe RDS patient does not respond to prone position, then I have to think about ECMO. So we divide our patients onto responders, non-responders. Non-responders, I ask ECMO team to come. Okay. Responders, okay, continue, no need for ECMO, and continue. What about the gray area? Gray area, which is responders, respond to ECMO, respond to prone position, but this response is not consistent. Mean it respond, then go back. So mean I respond during proning. When I go back to supine, the response is not good. I go back. I will consider the patient on the ECMO. I might put the patient on ECMO, but I might not. It depends. I have to give the patient chance. I will think about the age of the patient, days of mechanical ventilation. Is it viral or bacterial pneumonia? What are the bleeding risks? So if the patient is young age, early in your mechanical ventilation, I might go for it. If the patient is old and not a good suitable candidate for ECMO, I just carry on with the prone position, because I don't want also problems from ECMO, because the ECMO has issues. If you have patient have bleeding risk and everything, I will go for I will avoid ECMO. But if the patient is young, fit, and does not respond, or the response is not good for prone position, I'm talking about, of course, severe ARDS, ECMO will be the answer. Okay, so I will start with early proning. If respond well and good, if does respond, I go for early ECMO for non-responders. Of course, you have to consider the factors I've told you. Okay, should I carry on ولا كفاية كده عليكم؟
Yes, very, very good. Yeah, you are strained nearly about 2 hours. And we have a question and open discussion.
طيب انا مش عايز اصلا مش عايز ادي معلومات والناس ممكن حد مش فاهم ولا حاجه، فانا اول اوبن كويشنز، ولو عايزين ان شاء الله المره الجايه اديكم بارت 2 ان
شاء الله. ان شاء
بارت 1 وبارت 2. الحلقه اللي احنا عندنا حلقات زي المسلسل.
طبعا ربنا يكرم حضرتك يا دكتور ياسر. ويعني هي محاضره طويله، لكن يعني ما فيهاش دقيقه واحده فيها ملل يعني. Very dynamic, يعني starting from the history of ventilation to the up to ECMO, the recent. So very nice. Thank you, Professor Yasser. We have a question from Ahmed Al-Masri about the ventilation of acute core pulmonary and hemodynamic compromised patient. What about the PEEP and the plateau pressure adjustment in such case?
دكتور اسمه ايه؟
أحمد المصري.
ما شاء الله يا احمد، سؤال كويس جدا. طبعا الكور بالمونالي هو بيتكلم على لما يكون في رايت فنتريكولار ديسفانكشن. طبعا احنا عارفين اي بوست فنتريشن هي any can I speak in Arabic or English? Okay.
Yes. Okay. This is a question.
Okay. So anyway, we know that core pulmonary, you know, if you have positive pressure ventilation, this will put stress on the right ventricle, and already a patient is in core pulmonary. So this is one of the indications that we might need to do ECMO VA. I don't know if you, of course, if you don't have an ECMO center, you might need to do ventilation, but try to reduce your pressures, even during the inspiration, expiration, both. During inspiration to reduce your plateau pressure, during expiration, you, by giving PEEP, despite PEEP is a positive pressure, I told you it will reduce the mean airway pressure. Why? Because it will recruit more alveoli. So try to reduce your driving pressure. The driving pressure is the difference between the plateau and PEEP. You have to ventilate the patient, because the patient have ARDS. You cannot, the patient will die. You have to ventilate the patient, but try to reduce your pressures. Do prone position. Prone position will help also core pulmonary patients. Okay. So my lecture today is the answer to your question. My lecture today, by doing reduced mechanical power by doing less plateau pressure, by doing less mean pressure, by doing prone positioning, you are doing recruitment, you are reduce VQ mismatching, because VQ mismatching is one of the reasons for also pulmonary vasoconstriction, which also put pressure on the pulmonary artery and copulmonary. So we have to ventilate these patients, but do the minimum ventilation to achieve oxygenation. Of course, if you cannot, then you have to go for ECMO, maybe VA ECMO, but then if you don't have ECMO, at least maximize your good ventilation. Does this answer the question, Ahmed?
Ahmed is here. Ahmed.
Yes, sir. Yes, sir.
Ahmed, unmute yourself. Ahmed, unmute yourself. Is it enough answer for you, Ahmed, or you need
Yes. Yes,
some
yes.
to be clarified?
Yes, thank you, Dr. Yasser.
أهلا
Thank
وسهلا.
you. Thank you.
But good question. أنت ذكي يا أحمد، شاطر. اللي
Yes,
بعده.
شكرا دكتور ياسر.
he is one of the founder of our society and supporting his society by many ways.
ما
It's
شاء
good.
الله. أهلا وسهلا.
Thank you, Ahmed.
Thank you,
The
Dr. Safa.
Okay. The second question from Suhail. He is our Kenyan colleague, and he's so kind man, helping me so much in Kenya.
Hello, Suhail. How are you?
Suhail, are you here?
Walaikum salam. Alhamdulillah. How are you all?
Alhamdulillah. Sorry, I spoke in Arabic in the middle, but I thought
No.
but I'm now speaking English. Okay.
No worries. Thank you for a wonderful lecture. We learned a lot.
Alhamdulillah. Alhamdulillah. That's the whole idea.
Shukran.
أهلا وسهلا.
Suhail, you can deliver your question for Professor Yasser.
Yeah, I was asking, maybe I missed it out because I joined late. How do you measure esophageal pressure?
Okay, you measure esophageal pressure by put an esophageal probe like an NG, which can measure, has a pressure gauge. It can measure in the mid esophagus. You reach the mid esophagus, and a lot of studies have shown that that esophageal pressure, that esophageal gauge in the mid esophagus correlates well with the pleural pressure. The whole idea you are measuring esophageal pressure is to measure the pleural pressure, and measuring the pleural pressure. If you take away your alveolar pressure, this will give you the transpulmonary pressure. So transpulmonary pressure equal pleural pressure minus alveolar pressure. Alveolar pressure during inspiration called plateau pressure. Alveolar pressure during expiration called PEEP. You need to keep always positive transpulmonary pressure during inspiration. But the problem is not issue during inspiration. During inspiration, usually because we give positive pressure, usually is above the pleural pressure. The problem is during expiration. You need to adjust your PEEP to be above the transpulmonary pressure during expiration. Because, but usually it's okay in most patients, but in obese patients, or patients have chest wall rigidity, you might need to put this esophageal pressure in order to adjust the PEEP. Most of the patients, you don't need esophageal pressure, but if you have patients have, as I told you, obese patients who have a problem in the chest wall, you might need to use esophageal pressure in order to get the actual pleural pressure. And as I told you, Professor Tamer from Harvard have shown it reduces mortality by using esophageal pressure.
Thank you so much for explaining.
Is it okay, Suhail, for you?
Yes. Yes, thank you so much for explanation.
You need another question, Suhail?
No, I don't have any for now. Thank you so much for explaining very well.
You are welcome, my great son. Goodbye, Suhail. Goodbye. So we also have a question from Ahmed. If pressure control equal plateau peak, what happened?
Tani, what's
So, I don't know if this is from Ahmed Al-Masri or another Ahmed, ask about the pressure control peak equal to plateau pressure.
Peak equal to plateau, ما فيش حاجة اسمها كده. We need to have a...
Ahmed is here?
There's nothing called plateau equal peak. The plateau will equal peak in one condition when you do an inspiratory hold. When you do an inspiratory hold, you are stopping the flow at the end of inspiration, then the pressure measured will be the plateau pressure, the alveolar pressure. The peak and the plateau will be the same. But we do this intentionally just to measure the plateau pressure. But during the actual ventilation, you need to have a higher, because the peak means that you are not only ventilating the alveoli, you are ventilating also the airways and the tubing of the system. So you have added value above the alveolar ventilation, which is the ventilation through the airways and the tubing. So if you have any kink of the tubing and or bronchoconstriction, you will have the difference between the plateau and the peak will be higher, more than 10 centimeters of water. Then you think the problem is not on alveoli, the problem is in the airways or in the tubing. You got that? I don't know, is it obvious or not?
Yes, it's okay. If you wanted to clarify any point, we are ready. So Maha is our dear colleague, and she is my daughter in Menofia University. She's associated professor in Liver Institute. She asked about the best driving pressure.
Okay, best driving pressure is, as I told you, the best driving pressure is anything below, in some studies I've shown you below 18, Amato say below 15. I would accept up to 18, but the lower pressures, the lower the better, the lower the better. So as I told you, below 18 is a good number. So do you understand, Maha, the difference between what's the concept? The concept is we're trying to, driving pressure is the pressure between the plateau, the alveolar pressure, and the PEEP, okay? Doing inspiration, of course. So doing inspiration, when you ventilate the lung with positive pressure, you need to have this pressure above the PEEP, okay? If you have a severely diseased lung, you will need higher driving pressure, okay? So some people, in order to ventilate, they will increase the driving pressure. They increase, but this is not a good idea. Try to be maximum of 18. 15 is the better even. Don't do this. You will tell me, Dr. Tab, if I do this, this means I will not have enough ventilation of the lung. It's fine. I accept that. I will have higher CO2. I will have not enough ventilation, but I will not have ventilated associated lung injury. Okay? So try to reduce your driving pressure to less than 15 if you can.
Okay. We have a question also.
Is it Maha سبعة ولا مين ولا حد تاني؟
No, Maha Lutfi.
أهلا أستاذة Maha.
Are you here, Maha? Are you here?
Are you okay? Do you understand the question, the answer? Okay with this?
Maha, are you here?
خلاص, okay.
Yeah, can Ahmed also ask, another Ahmed ask about can we depend on transpulmonary pressure although we do not measure esophageal pressure?
يعني you'll assume, يعني you not have an accurate measurement. I mean, there's no way you can assume. You can يعني كان في طريقة زمان you can put a stethoscope on the side and feel, but it's not accurate. You
Yes.
can,
Yes.
but I mean you can, but it's not accurate. The best way is to put esophageal pressure.
Okay. I have a question from
But don't feel bad if you don't have esophageal pressure. Don't feel bad. As I told you, it is only in certain patients who are obese patients difficult to ventilate. But most patients you can follow the table I told you. The table I told you from the RDS network.
Yeah, we have a question from Abdul Alim. He asked about in case of ARDS, if we need to increase the FiO2 and PEEP to reach the target of SpO2 more than 92%.
صح. ما هو ده اللي احنا بنعمله.
Yes, yeah.
Yes, but I added to you.
Relative to PEEP, yes.
I added to you also another thing, which is proning position.
Yes.
I added to you also the IE ratio. So
Yes.
how to improve oxygenation? You increase the FI2. This is the simplest thing. Severe hypoxia, increase FI2. Yes. You increase your PEEP according to the PEEP table. The next thing you can do prone position. Also, do IE ratio. The IE ratio, as I told you in the lecture, instead of making 1 to 2, you can increase to 1 to 1. Even you can do inverse ratio ventilation. These are the methods to how to improve oxygenation during ventilation. How to increase oxygenation by applying PEEP, by increasing the IE time, 1 to 1 or even 2 to 1, by do prone position. And of course, increase FI2. These are the things to improve oxygenation.
Yes, finally, it may not be the playing with the wolf, it is playing with the numbers. In case of ARDS, playing with the numbers to have the optimum and best result. Yes, it is not playing with wolf. Yes, Ahmed Al-Masri have another question. Ahmed, you can unmute yourself and deliver your question about the surgical refractory hypoxemia. تفضل يا أحمد.
In those patients with severe ARDS with refractory hypoxemia due to patent foramen eval, any patent foramen eval.
Patent foramen eval,
Is there any intervention away from apart from the surgical intervention to improve the oxygenation?
انت بتسألني يعني من ناحية الفنتليشن يعني؟
Yes.
ما هو ده، ما انا جاوبته في المحاضره. انت قصدك ايه من ناحيه ايه؟ بس معلش مش فاهم بالظبط.
يعني most of these patients they have refractory hypoxemia because of patent foramen eval.
عندهم شنط.
Yes.
الشنط في الهارت.
Yeah. Is there any treatment apart from the surgical intervention? They might benefit from proning, nitric oxide.
طيب طبعا. لا بس انت انت عايز تعالج ده باللي انا بقوله يعني؟
Yes.
انا ما فكرتش في حاجه زي كده، بس ممكن. بس احنا دلوقتي بنتكلم على الشنط اللي جوه اللنجز. يعني العيان عنده البيشنت الشنط inside the lungs because of inflammatory process، فعنده كولابس الفولاي، في البلاد بيعدي من حته لحته ما فيش. انت عايز تزود كمان ان هو كمان عنده cardiac element of the shunt. Of course if you reduce the ventilatory part او lung part you might help in his total shunt. يعني total لو مثلا الشنط مثلا 60% شنطد و30% من اللنج و30% من الهارت، انا مش الحبه بتوع اللنج دول مش هيأثروا في الهارت لان الفورمن اوفال دي مفتوحه لازم تتقفل بالسيرجيكال. بس اتليست انت بدل ما كان 60% 30% بتاعتهم لنج، على الاقل انت قللت له بتوع اللنج. يعني لما تحسنوا البرونيك هتحسنوا الحبه بتوع اللنج.
Yes, yes.
Yes, the pulmonary condition should be promptly cleared to avoid pulmonary hypertension and reverse shunt via the foramen oval.
ده حاجه ثانيه بقى. ده عايز المنكر بقى.
This is the way يعني. This is the way.
طبعا.
Yes.
كلام حضرتك صحيح.
Yes.
كلام حضرتك صحيح.
Yes. But if the foramen oval have left to right and not compromising the systemic circulation, nothing to be done. After complete recovery of the pulmonary condition, we can go to surgical correction of patent foramen oval.
مظبوط.
So we have question from Muhammad Eid and Dr. Abdul Alim raising his hand. So all the question will be clarified. I'm so sorry, Dr. Yasser. I know that you are so tired, but excuse me, we have the last question. Dr. Abdul Alim.
أنا معاكم لغاية الفجر.
شكرا. Dr. Abdul Alim, you can stream your question. Unmute yourself, please.
السلام عليكم.
وعليكم السلام.
معكم.
اتفضل.
شكرا على المحاضرة الطيبة. بس سؤالي كان كالتالي، يعني هل لازم في حالة رفع ال FiO2 لازم أرفع البيب في حالة ال ARDS، وإلا مثلا أحيانا يدخل المريض ARDS أول ما أحطه على 80% وأحطه مثلا أو 100% FiO2 ممكن أحط البيب على 6 7 التارجت يصل 92 93. أقصد أنا هل لازم أنقص ال FiO2 وارفع البيب بالمقابل علشان الجدول اللي حطيته حضرتك أول المحاضرة إنه
في حالة
أرفع البيب 5.
أجاوب عليك. أيوة.
أنا أقصد هل لازم يكون بالتساوي الرفع، والا
أيوة.
اهم حاجه اصل للتارجت الاف اي او الاس بي او 2 مور ذان 92. شكرا.
دكتور عبد العليم، دكتور عبد العليم، ده الفرق بين انك ما حضرتش المحاضره قبل ما تسمع المحاضره وبعد المحاضره. انا عايزك ترجع المستشفى بتاعتك تغير البراكتس بتاعك. لو انا ما نجحتش ان انا اقنعك انك تغير براكتس وترجع تعمل اللي انت كنت بتعمله زمان، يبقى انا ما عملتش حاجه. انا حاولت اقنع حضرتك بالفسيولوجي وبالايفيدنس. الايفيدنس بيقول الدكتوره مها سالت سؤال، هو اجابه السؤال الدكتوره مها لطفي اللي قالته في الاول هو ده الدرايفنج بريشر. يا دكتور، انت لما دلوقتي لو انت اتشيفد، انت وصلت لنفس النتيجه بس ببيب قليل، معنى كده ان الدرايفنج بريشر بتاعك عالي. ليه؟ لان البيب القليل لو تطرحه من البلاتو بريشر هيديك درايفنج بريشر عالي. خلاص؟ لان دلوقتي انت مثبت الدرايفنج بريشر، انت مثلا بتدي بلاتو بريشر بتاعك مثلا 25، حلو، والبيب بتاعك 5، يبقى انت بتدي 20 درايفنج بريشر. لا، انا عايزك تطلع بالبيب عشان تقرب من البلاتو، يبقى الديفرنس بين بوث قليل، لان ده الدرايفنج بريشر ده بيأثر في المورتاليتي يا دكتور، وامات واثبت الكلام ده على الاف المرضى. فالدرايفنج بريشر از فيري امبورتنت. يعني لو انا اتشيفد ذا سيم نمبر، يعني سؤالك انا عاجبني سؤالك ليه؟ لان هو ده الناس فاهمه كده، المهم عندي ان انا عندي ساتيشن كويس وخلاص. لا، لو انا وصلت لنفس النتيجه بس بطريقه مختلفه، لا، الطريقه تفرق. مش الغايه تبرر الوسيله، لا، الوسيله لازم تكون صح، لازم تكون ايفيدنس بيست. فالايفيدنس بيست بيقول ان انا اقلل الدرايفنج بريشر. ازاي بقى؟ ان انا اعلي البيب. الهدف من الجدول ده ان انا اعلي البيب. لما اعلي البيب هقلل الديفرنس بين ذا بلاتو اند ذا بيب، فالدرايفنج بريشر بتاعي يقل. وانا وريتك انا يعني كان فيك، تحب افكرك بال دي اماته اهو.
بس انا كنت اشتي اوصل الى درجه الوضوح بهذه الرؤيه فعلا، انه لازم
أيوة،
ننقص الدرايفنج بريشر
اهو
فعلا.
اهو يا دكتور، اهو اللي انا قلت له عليه. لازم ترفع البيب اهو، رايزنج، لازم ترفع رايزنج بيب. هو قاعد هو شاف المرضى 3500 مريض، شاف الناس اللي عامله زي حضرتك كده خلت البيب قليل ورفعت البلاتو وحققت اللي هي عايزاه. لا المورتاليتي عندهم عاليين. ده خلي بالك كوت برسبكتيف ستادي، يعني هو شاف، خلي بالك هو بص على كل الحالات اللي من سنه 2000. خلي بالك الاي ار دي اس نتورك ستادي بصت بس على التارد فوليوم، ما بصوش على درايفنج بريشر. فالناس، ففي بعض اليونس عملوا زي حضرتك، وفي بعض اليونس عملوا زي يونس تاني. ففي ناس كانت مخليه البيب صغير والبلاتو عالي، فالدرايفنج بريشر كان، فلقى المورتاليتي عندهم عاليين، ده ريتروسبكتيف. وبص على ناس كانوا معالين الاثنين، لا قسموا ثلاثه. لا بقى في الناس اللي كان عندهم بلاتو سيم والبيب قرب من بلاتو، لا المورتاليتي عندهم اقل. واضح ولا لا؟ فانا انصحك يا دكتور بعد اذنك انك تروح تعلي البيب نيكست تايم. لو لقيت ان العيان محتاج اف اي 2، محتاج سيفير ار دي اس، اعلى بالبيب.
اوكي،
شكرا.
اهلا
دكتور
وسهلا.
عبد العليم، it's okay for you دكتور عبد العليم.
وضحت ولا لا؟
شكرا. ايوه وضحت. شكرا.
Okay. So we have a question from Dr. Muhammad Aid. Dr. Muhammad, are you here? Dr. Muhammad. Really, I don't understand his question very well, but he can be also if the patient is deeply sedated or on muscle relaxant and no bronchospasm. What is the concept of? I don't know this comment or what, but his question is, what is the concept of power of ventilation?
حلو.
He's asking about the mechanical power.
ميكانيكال باور. طيب الميكانيكال باور بسيط، الموضوع بسيط. انا قلت لكم الميكانيكال باور ده هو انت دلوقتي الفنتليتور ده ماشين جديده على الانسان، يعني احنا بنتنفس بدون فنتليتور، فاحنا الفنتليتور ده حطيناه حاجه جديده فبيدي باور. وجدوا ان كل ما نزود الباور اوف فنتيليشن بيزود المورتاليتي. حلو. ايه الباور اوف فنتيليشن؟ لقوا كل ما تزود الريت، عدد خبط، انت قاعد تخبط المريض كل شويه 30 35 مره، يبقى ده باور. بتديله تايدر فوليوم كبير، بريشر عالي، كل الحاجات دي بتزود الباور. كل ما تزود الباور كل ما الافكت الانجري بتاع الفنتليتور اعلى. هو ده الفكره، ان انا كل ما اقلل الباور، ان انا ازاي كان الناس زمان علشان تحاول توصل للجود مينت فنتليشن هي محدوده بايه؟ الاستادي بتقول لها امشي لو تايدر فوليوم، فروحوا مزودين الريت. لا، حتى ده وجدوا ان الناس اللي زودت الريت مش صح، برضه ما تزودش الريت، لان ده هيزود لي الباور. فهمت الكونسيبت الباور جه ازاي؟ لان الناس كانت بس بتفكر في التايدر فوليوم، بس لو تايدر فوليوم وخلاص، وازود الريت براحتي. لا، ما ازودش الريت براحتك. برضه نفس حكايه درايفنج بريشر، الناس ما كانش حد بيفكر في الدرايفنج بريشر. انا شخصيا كنت من ساعه الاستادي كنت يهمني بس التايدر فوليوم بتاعي كويس، لو تايدر فوليوم وخلاص، فالعب بقى في البايدر واخلي الفرق بين البيب انا نفسي كنتش فاهم لغايه لما قرينا الاستادي دي وغيرنا الباكس. انا نفسي غيرت الباكس بتاعي، ان انا خليت دلوقتي قللت الباور، لا اقلل الدرايفنج بريشر بقلل الباور، لا اقلل الاسبيراتوري ريت اقلل الباور. واضح؟ وضحت ولا لا؟
Yes, of course. Is not here. I don't know. Is it clear
لا
for
بس
him?
وضحت للي بيحاول في حد علق.
He can come back and
طيب.
if you want to clarify anything, we are ready.
اللي قصدي اللي علق يمكن صاحبه يوصل له المعلومه.
Yeah, it's okay. Hannah asked about, is the mechanical power of ventilation the new term of VILI?
مظبوط صح، هو كورليتنج الميكانيكال باور كورليتنج فور VILI صحيح. الوقت كل الاستاديز لو انت بس اكتب كده بس ميكانيكال باور في الميد لاين ولا حاجه، هتلاقي استاديز كتير دلوقتي بتحسب الميكانيكال باور دي. خلاص.
اوكي.
انا ممكن اشرح لكم محاضره كامله عليها انتوا لو عايزين يعني، بس انا بقى يعني هي المعادله، لو اوريكم المعادله اهي، المعادله اهي عشان الناس اهي، هي المعادله. ففيها المعادله بص كل ده محسوب مضروب في هي معتمده على الثلاث حاجات دول. الريسبيراتوري ريت اهو طبعا، في او الريسبيراتوري دخل جوه كمان خلاص، وكمان التايدر فوليوم والتايدر بريشر والبيب طبعا.
والبيب.
طيب.
also دكتور
مكتوب
موفق.
اهو ريسبيراتوري ريت قول اتفضل.
دكتور موفق our Syrian colleague, you know him, دكتور ياسر, our Syrian colleague دكتور موفق.
اهلا وسهلا من سوريا.
دكتور موفق.
دكتور موفق اهلا وسهلا.
اهلا.
انا اسف اتكلمت انجليزي كتير.
معلش هو هيسامحنا.
الله يسلمك. والله انا سؤالي ممكن اشرحه بالانجليزي او بالعربي حسب ما تحب.
يلا بالعربي. يلا يا دكتور موفق اتفضل. طبعا
هو السؤال انه الفلو ريت، يعني الفلو يعني المنفسات او الفنتليتر، النيو فنتليتر بتعطي فلو عالي 10 لتر، يعني 10 لتر بير مينت او 20 لتر بير مينت او 30 لتر بير مينت، يعني له علاقه بقيمه البيب وقيمه البلاتو، التحكم بالفلو نفسه.
طبعا كل ما تزود الفلو كل ما هيزيد. انت عشان كده هو الفنتليتور المفروض لو الفنتليتور فلو ديبندنت المفروض تزود الفلو از ماتش از يو كان. ده بتعرفه ازاي؟ بكيرفز. انا عندي محاضره على الكيرفز فممكن نشوف الفلو. بس هو الفلو كل ما زود الفلو طبعا وعلى حسب انت بتستخدم، هل هو انت فلو ديفايدر يعني نفس المود بتاعك ده الفنتليتور. انا مش عارف تستخدمه ايه عندكم، بس في فنتليتور بيقسم الفلو، يعني بيبقى انت بتدي الفلو وبيشتغل ان هو فلو ديفايدر او بيسموه تايم يعني اللي هو بيغير السبيشال اكسبريشن بناء على التايم، على الفلو، بيقسم الفلو ويقسمه على التايم. فطبعا لازم يهاف انف فلو عشان يعمل الحكايه دي. طبعا بتحسبه ازاي؟ بتحسب قد ايه انت محتاج تايدر فوليوم وقد ايه محتاج الريت وتقسم كده. ده محاضره ثانيه عن المودز. انت كده دخلتني في المودز فنتليشن. انا ما شرحتش المودز. انت في محاضره كامله عن المودز فنتليشن ممكن اشرح فيها واشرح لك اكتر
ان شاء الله. نشوفها مره ثانيه ان شاء الله.
دكتور موفق، انت لسه حضرتك عايز تسال الدكتور ياسر في حاجه في الفنتليتور بعد الكورس؟ مش ممكن.
الكورس احنا شرحنا الكورس.
فاكر احنا كنا بناخده بالعافيه من
والله الدكتور ياسر مشكور، الحقيقه تعب ساعتين وربع يعني. ان شاء الله الله يدير خير.
طبعا
حبيبي
طبعا ربنا يبارك في عمره. والله يا دكتور موفق ربنا يبارك في عمره وفي عمر حضراتكم. يعني تسلمنا على كل الجروب دكتور موفق بعد اذنك.
انا والله سعيد ان سمعت صوتك.
طبعا اخونا.
الله يسلمك. يسأل ان شاء الله. مشكورين.
الله يكرمك الله يكرمك الله يكرمك. Anyone from the floor have a question, please, my colleagues, my dears?
انت سجلت المحاضره يا دكتوره صفاء؟
طبعا طبعا.
طب كويس، عشان قصدي لو حد عايز يسمعها بعد كده ولا حاجه.
طبعا طبعا، هي بتبقى على التليجرام، هم عارفين، عشان كده يعني ما شاء الله والعدد كويس جدا. هم بيبقوا معتمدين على اختنا هناء الحداد فروم ليبيا، بتبعت لحضرتك السلام وتقول لحضرتك جزاكم الله خيرا، رائعين كالعاده يعني. شكرا لكل اخواتنا في ليبيا، ويعني ان شاء الله ربنا يربط على قلوبهم ويعوضهم خير يعني. واحنا دايما في انتظاركم، ودايما مشاركاتكم بتسعدنا بصراحه يا هناء. هناء انت موجوده؟ هناء؟
ايوه دكتوره صفاء، بس انا مش من ليبيا.
طب سوري، انا افتكرتك هناء الحداد يعني، لانها دايما بتسال. هناء مين؟
هناء
فتوح.
لا، هناء سعيد، معهد الكبد.
اهلا وسهلا، اهلا وسهلا. معهد الكبد من عند الدكتور خالد ياسين يا دكتور ياسر.
طبعا استاذنا.
اهلا وسهلا، اهلا وسهلا هناء. ليكي سؤال يا هناء؟
لا الحمد لله دكتوره صفاء، محاضره رائعه بصراحه.
ما شاء الله ما شاء الله.
استفدتي يا دكتوره هناء؟
جدا يا دكتور والله.
طب ما فيش اي تعليق يعني؟ انا كنت مثلا
ما انا اللي كنت الحمد لله، انا كنت بس المصطلح بتاع الميكانيكال باور وحضرتك جاوبت عليه يعني، الحمد لله.
طيب الحمد لله. انا ما حبيتش ان انا اصور الموضوع، عايز شرح شويه، ما حبيتش انا ادوس على الناس، انا مش عارف مستوى الناس كلها ايه. لكن هو دلوقتي حضرتك زي ما شرحته، هو يعني انا سايب جاتانوني كاتب فيه قوي وكتير يعني من بس هو الكونسيبت بتاعه بسيط. الكونسيبت اللي انا قلته هو ده اللي انا شرحته لحضرتك، ان هو كل ما نزود الباور الفنتليشن، كل ما نحاول نقلل حاجات اللي بنعملها في الفنتليتور كنا يبقى اقل.
صح. دكتور عبد العليم بيشكر حضرتك طبعا، وفي احمد المصري تاني. احمد المصري النهارده نجم الحلقه يعني، ربنا يفتح عليه فتوح العارفين. قول يا احمد سؤالك. انت مش
معلش يا دكتور ياسر، بس احنا بنحسب الريسبيراتوري اليستنس ازاي؟
الايه؟
ريسبيراتوري اليستنس.
الاسنس عكس الكومبلاينس. خلاص؟
يعني واحد على الكومبلاينس؟
واحد على الكومبلاينس عكس الكومبلاينس. انت عارف ازاي بتحسب الكومبلاينس؟ طيب بتجيب البريشر وتجيب الفوليوم، ولما تطلع الكومبلاينس واحد عليه يبقى يطلع الالاستنس.
تمام شكرا.
يعني مثلا لو انا هفنتليت هقول لك اهو، لو انت بتاخد مثلا تاخد فوليوم دلوقتي وانت سبونتينيوس بريدنج، مش كنترول ولا حاجه. دلوقتي سبونتينيوس بريدنج انت بتاخد تاخد الفوليوم بتاعك كام؟ خليها 500، خليها 400. خلاص ماشي. وانت النيجاتيف بريشر عشان الدايفرام بينزل ويعمل لك نيجاتيف بريشر بقد ايه؟
-5
-1 تو -2 صح ولا ايه؟ صح كده؟
يس.
يبقى كل ال 400 دي محتاجه من 2 سنتيمتر ووتر عشان تدخل 400 جوه اللنج بتاعتك، صح ولا لا؟ خلاص يبقى الكومبلاينس بتاعك قد ايه؟
كده تقريبا 200
صح. اللنج كومبلاينس بتاعك 200، ده بس اللنج، خلي بالك مش جوه الشيست وول. لو حطيتها بقى جوه الشيست وول، خلي بالك الشيست وول عايز يطلع واللنج عايز يدخل، ففي بينهم الاثنين. فاحنا لو اللنج جوه الشيست وول الكومبلاينس بتاعنا بينزل ل 100. خلاص
تمام.
هم اثنين عكس بعض. فانت عايز تحسب بقى لو انت جبت الكومبلاينس بتاعي 100، ده الكومبلاينس 100. لو انت عايز تجيب الاسنس يبقى 1 على 100. واضحه ولا لا؟
تمام تسلم.
اتفضل يا باشا.
في اني كويشن يا جماعه؟ دكتور ياسر جزاكم الله خيرا يعني، ونفع بكم يا رب، اللهم امين، واجعلك من اهل العلم النافع، وكتر خيرك، ومحاضره رائعه الحقيقه. وانا عارفه ان حضرتك لما بتيجي تتكلم في الفنتليشن كانك بتعزف على البيانو يعني، ما شاء الله. الله اكبر الله اكبر يعني، 5 في عينيا يعني.
لا ما شاء الله. انا طبعا ما كملتش في حاجات كتير لسه ما اتكلمتش فيها.
ان شاء الله الايام
فان شاء الله بقى الحلقه الجايه. وعندي برضه محاضره هوصل معاكم لكل حاجه. بص لسه كده محاضره، وكمان هوصل للباي ليفل والاي بي ار في. في ناس كتير عايزه تفهم اي بي ار في. لو حبيت الموز،
احنا عندنا هيوج ثبتات قد كده، هبعتها لحضرتك اللي فاضيه كلها.
والهاي فريكونسي فنتيليشن وعندي اكمو وعندي حاجات كتير قوي.
انا عارفه ان حضرتك يعني مولع بالفنتليشن وبتحبها، واحنا كنا لما كنا بندي الكورس كنا بنشد حضرتك ناسيه. هو في عبده كان رافع ايده، معلش يا دكتور ياسر انا متاسفه جدا. عبده انت فين؟
اهلا يا عبده.
عبده
ايوه السلام عليكم. السلام عليكم.
احنا اسفين، هو مكتوب عبده بس، فانا اسفه.
لا
يعني
انا الدكتور ناجي نجم، بس هو داخل في تليفون حد.
ناجي
ابني.
مين عبده ده؟ ناجي
ابني.
الله يسامحك يا اخي. طب يلا يا
دكتور ياسر حبيبي طبعا، قصر العيني، وانا كنت معاه في القصر العيني وهو حبيبي.
طبعا
انا
ناجي نجم يا دكتور ياسر.
88.
نعم طبعا دكتور ناجي نجم ده استاذنا وراجل من الناس المحترمين.
انت بعدينا
هو فاهم لما بقول له من الناس المحترمين هو فاهم.
ربنا يكرمك. كنت عايز بس حضرتك يعني محاضره رائعه يعني انترستنج، هي كنا عايزين نفرق بس بين ازاي نعرف الاير واي ريزيستنس ولا لانج ريزيستنس على في البريشر دي.
ده
يعني
سؤال انا عاجبني السؤال ده، حلو جدا. بص حضرتك، انا بنعمل اللي انا قلت عليه ده، اللي احنا بنعمل انسبيراتوري هولد at the end. انا عندي عندكم وقت افتح حاجه تانية، افتح برزنتيشن تانية؟
لا
طيب
عشان في ناس كتير لفت، كنا احنا حاجه قريب من 50 بقينا حاجه و20.
خلاص طيب على العموم بص حضرتك،
ونجي يستحملنا نبقى نقولها له.
لا بس هقولها بسرعه. بص يا دكتور، هنعمل اسباتو هولد، وبعدين لما نعمل اسباتو هولد الفلو هيقف، فالفلو يقف، فمقاس البريشر هيقيس لي الالفولار بريشر. حلو، فالالفولار بريشر ده هو البلاتو. تمام كده؟ طيب خلاص. طيب الديفرنس ده، لو الديفرنس ده اكتر من 10، يعني لو انا البيك بتاعي مديني 45 وانا قست البلاتو بتاعي لقيته مثلا 20، يعني في 15، يبقى انا عندي اير ريزيستنس 15. خلاص، يبقى انا ادي العيان ده ممكن يكون، لو انا اتاكدت ان مفيش حاجه في التيوبنج، يعني التيوبنج بتاع الفنتليتور ومفيش حاجه في التيوب نفسها اوبستراكتد ولا حاجه، يبقى ده والعيان عنده ويزز، يبقى المشكله في الايه، محتاج ان انا اديله فاز بونكو دايليتور ولا حاجه توسع الايه الالفيلاي. هي مشكله اير واي مش مشكله الفيلاي. ده كان سؤالك ولا انا فهمت حاجه غلط؟
ايوه هو بس كان على البريشرز، يعني بين البلاتو بريشر والبيك والبلاتو
الفرق يكون من الفرق المفروض 5. الفرق المفروض 5. اكتر من 5 يبقى مشكله اير واي، اكتر من 10 يبقى مشكله كبيره. المفروض ما يعلاش اكتر، المفروض النورمال من 5 ل 10، المفروض دايما يكون 5 او اقل. من 5 ل 10 يبقى في مشكله، من 10 وطالع يبقى لا، لازم احل المشكله دي.
تمام، تسلم، جزاك الله.
والرقم اللي بيطلع لحضرتك دايما في الفنتليتورز كلها اللي بيطلع ده مش هو البلاتو، مش هو الالفولار بريشر، ده البيك. عشان اجيب البلاتو لازم اروح وادوس، انا بروح على الفنتليتور اعمل حاجه اسمها سبيشال مانوفر، وادوس على حاجه اسمها سباتو هولد، واستنى ثانيتين. لما استنى ثانيتين هيطلع لي البلاتو. لما يطلع البلاتو هيطلع لي مثلا 20، اشوف البيك بتاعي كام. لو 35 يبقى عندي مشكله في الايرواي، يبقى انا لازم احل المشكله دي.
ايوه تمام.
واضحه؟
واضحه كده، تمام. شكرا، جزاك الله.
انا عندي محاضره كامله على الحكايه دي، بس مش كان ممكن افتحها، بس الدكتوره صفاء خلاص.
معلش عشان الناس بس يعني مشيوا، فانا هستخسر ان احنا نعرف حاجه هم ما عرفوهاش يعني.
لا ما خلاص، هي نفس الكلام، هي بس كنت، لا هي نفس اللي انا قلته، بس كان على دايجرامز يعني.
بالظبط.
اوكي.
ربنا يكرم. هو ناجي ما شاء الله متواصل معانا طول الوقت، وبرده ناس ده من الاميننت والفاوندر والسبورتنج جامد للجمعيه، فربنا يكرمه يا رب.
ناجي ضيف كبير من اصل عيني.
ربنا يكرمك.
دكتور ياسر، كل الشكر والتقدير والاحترام لحضرتك، يعني اخونا العظيم واستاذنا الرائع، وكتر خيرك على المحاضره الحلوه دي، وهبعت لحضرتك السبتات الفاضيه عندنا كلها ومنتظراك تاني. شكرا جزيلا لحضرتك، وتصبحوا على الف خير. شكرا لحضرتك.
وعليكم السلام.
شكرا يا دكتور ياسر، شكرا، اشوفك بخير ان شاء الله.
السلام عليكم، دعواتكم ان شاء الله.
شكرا.